pleasure to introduce my colleague, Dr. Abdulrahman Albloushi. He is a new member of our department in the Department of Ophthalmology at King Saud University. Dr. Abdulrahman is a consultant in medical retina and uveitis and assistant professor at the Department of Ophthalmology, King Saud University. Dr. Abdulrahman carries the Saudi board in ophthalmology and King Saud University Fellowship in Ophthalmology. He's also a fellow of the Royal College of Physicians and Surgeons of Glasgow, UK. Dr. Abdulrahman did his medical retina and uveitis fellowship at the prestigious Moorfields Eye Hospital in London, UK. He has several publications in high-impact journals, and it gives me, again, great pleasure to introduce him for his lecture today about primary inflammatory choriocapillaropathies, insights from multimodal imaging. تفضل دكتور عبد الرحمن.
Thank you, Dr. Abdullah, for the nice introduction. It gives me actually the great pleasure to present the grand round today, which will be about the primary inflammatory choriocapillaropathies. I'm not sure if Abdullah, is my screen is clear now?
It's clear.
Okay. So first of all, I have no financial conflicts of interest to disclose. Before I start, we all know that nowadays most of the uveitis specialists, or some of the uveitis specialties, still use the term white dot syndrome or white spot syndrome, and we don't know if it's really white or yellow. And these terms actually was used before the invention or arrival of the multimodal imaging, especially the ICGA. So as we can see that all these are white dot syndromes, and most of these diseases are not related to each other. So it is now accepted by most of the uveitis specialists. This term should not be used in the area of multimodal imaging, and we should be more precise when we describe these entities. So after the arrival of the ICGA, the term primary inflammatory choriocapillaropathies was used to describe a group of the diseases in which the choriocapillaris involvement is the primary cause of the disease in these entities. And these diseases, share several things that happen in young patients, and often preceded by a viral prodrome, and this area, and it's associated with white or yellow areas that is either isolated or coalescent. It has a characteristic finding on ICGA that show choriocapillaris ischemia that persists for all ICG frames, and most of those patients tend to be myopic patients. So this group of disease included the MEWDS, multiple epithelial white dot syndrome, MP, acute retinal pigment epitheliopathy or Crill's disease, multifocal choroiditis, visionous choroiditis, unilateral acute idiopathic maculopathy, acute zonal occult outer retinopathy, acute macular neuroretinopathy. So with the invention of the multimodal imaging, when you look to the literature to examine each disease specifically, the problem is each disease passed through different stages. And if you find one case report that describes the disease in a specific timeline, you cannot comment actually on the whole process. That's why it's very difficult to find one article to summarize everything at different stages, different modality of imaging to describe the activity of the disease. Especially nowadays, for the last few years, with the arrival of the angio-OCT and adaptive optics, we see a lot of case reports about the primary inflammatory choriocapillaropathies, talking about the pathophysiology, and a lot of debates occurred after the innovation of these two machines. So I will talk about a group of the disease that usually present with acute disruption of inner segment, outer segment zone, the photoreceptor layer. And those patients usually present with photopsia, scotoma, and sometimes with enlargement of the blind spots. A group of the disease can all cause the same thing, which includes the MEWDS, the AZOOR, and AMN, multifocal choroiditis, and some of the masquerades. And these diseases, when first described in the literature, Gas linked all these diseases to be a part of AZOOR complex. However, nowadays, with the arrival of the multimodal imaging, we clearly know that those diseases are not similar. So for the MEWDS and AZOOR, there is also a or I can call it mini disease, like mini MEWDS. It's called AIBSE, acute idiopathic blind spot enlargement, where the disease is localized only around the optic disc. AZOOR also can present with a variant called acute annular outer retinopathy, which also involve the area around the optic disc. We should not forget the masquerades like a syphilis. So nowadays we have a syphilis in Saudi Arabia, and those can present with with a disease called acute syphilitic posterior placoid chorioretinopathy, and they present with a MEWDS-like picture. So for the MEWDS, it was originally presented in ARVO in 1983 and in print in 1984. It tends to be unilateral most of the time. However, bilateral disease was reported. It happens in young myopic females, usually preceded by prodromal symptoms in 2/3 of the patients. And most of the time, we don't require any treatment. Those patients can have a variable visual loss, and visual recovery usually occur within few weeks after the onset of the disease. He likes to call this a disease is a common cold of the retina, because usually there is a hypothesis that it happened after the viral infection, and the self-evolution of the disease is commonly happened without any treatment. So usually those patients present with blurred vision, shimmering photopsias, dyschromatopsia, and paracentral scotoma, or enlargement of the blind spot. And clinically, you will see these lesions as ill-defined, round, yellowish lesions in the perimacular area and occasionally peripheral to the arcades. And commonly, when you examine the fovea, you will see this foveal granularity. Autofluorescence is very characteristic, and you will see these areas of hyper-autofluorescence, which corresponds to the area of photoreceptor loss in the OCT. And if you do FFA and ICG, you will see a very characteristic hyperfluorescence in the fluorescein angiography. It has a name called wreath-like because it affects the only area of the photoreceptor damage. This area is corresponded exactly to the ICG hypofluorescence, which we can see in these two images. So based on this image for many years, people, because of the ICG finding, people were thinking this is most likely a choriocapillary disease because the ICG show hypofluorescence. And you can see from the OCT, the top one is during the acute stage, and it's very clear. You can see that the outer retina or the photoreceptor layer is affected. However, in the lowest picture, the photoreceptor layer starts to regenerate again. And this is the natural history of this disease. Recently, in 2016, Francisco Picchi, he's a uveitis specialist working at Cleveland, Abu Dhabi. He published his first paper regarding the angio-OCT in MEWDS patients. And he discovered that those patients don't have a choriocapillaris involvement. And the disease is localized only at the photoreceptor layer, as you can see in the top picture to the right. He demonstrated these hyporeflective spots and hyperreflective dots at the ellipsoid zones and the outer nuclear layer. And when he examined the choriocapillaris, he could not find, in this picture, he could not find any abnormality or flu void at the level of the choriocapillaris. So he hypothesized that the ICG findings occur because of the area of the sick epithelium did not take did not fix the ICG, as you can see in the right side, where the normal RPE usually uptake the ICG during the indocyanine angiography. So this area without ICG uptake usually show hypofluorescence in the ICG, and that's why it show a hypofluorescence in the ICG in the all frames. Thereafter, a paper by Carl Harbert, he demonstrated that, or he was argued that the disease is a primary choriocapillaris and not, a photoreceptor or RP disease. And in this paper, he was commenting about two things. First of all, the OCT angio should not be used to test the choriocapillaris, as this disease, the MEWDS, sometimes can have slowness of the blood flow in the choriocapillaris, which cannot be detected by the angio OCT. However, the ICG can detect these things. And after this paper, Giovanni Stawinghi from Italy, he published a very nice paper last year and he tried to solve this problem. So Giovanni, he demonstrated in his paper that the choriocapillaris was also intact. So there was no capillary flow void in those patients. However, he could see the changes at the level of the RPE and photoreceptor layer. So this is one of his patients when he did an ICG, and he found this area. You can see to the top to the left that there is an area of hypofluorescence corresponding to the area of photoreceptor loss. And 2 days after the ICG, he did another photo without injecting the ICG, and he found more lesions that causing hypofluorescence. So he was arguing that those patients, the cause of this hypofluorescence is not due to the choriocapillary shutdown, because without injecting the ICG, these lesions start to appear in ICG camera. So this diagram, which was mentioned in his paper, is a very nice diagram to demonstrate the three theories. The first one is the column A is the choriocapillaris hypoperfusion theory. The column B is the photoreceptor damage theory, and the column C is RPE swelling and melanosome rearrangement theory. So in column A, you see that the theory of choriocapillaris is not true, because the choriocapillaris angio-OCTs can show normal choriocapillaris. And the other thing, the hypofluorescence in the ICG was corresponding exactly to those in fluorescein angiography, and more lesions appeared 2 days after the injection of the ICG, and that cannot be explained by the choriocapillaris shutdown. Regarding the photoreceptor theory, you can see that in the middle column, the OCT signal hypertransmission was detected there, which cannot be explained by the photoreceptor damage. Most likely there was an RPE affection that caused reverse shadowing in this area. And you can see also when they used the adaptive optics, the images taken at the inner segment, outer segment was not equal, and the photoreceptor at the level of the outer segment was affected more, which may represent that the lesions start from the RPE, not the photoreceptor. And when you look to the third column, column C, you can see that the hypertransmission was detected in the RPE and nothing in the choriocapillaris OCT slab, and the presence of the photoreceptor, the outer photoreceptor segment is affected more than the inner segment, is suggesting more of the RPE theory rather than photoreceptor theory. Another, case report using adaptive optic to test the MEWDS patients. They found that, if you can see top to the left, adaptive optics at the level of the photoreceptor layer, there was an area of photoreceptor loss that was detected in the acute stage. And if you look down in the same area, these cone mosaics start to regenerate a few weeks after the observation. The pictures in the right side, D and E, is just for a control group during this period of time. What is more interesting is about the MEWDS is the autofluorescence, because most of the uveitis specialists nowadays diagnose MEWDS based on the OCT and autofluorescence. So David Sarraf recently, he described a very interesting findings in autofluorescence, which is dots on spots phenomenon. You can see this patient is the MEWDS patients who presented few weeks after the initial symptoms, and you can see these dots that causing hyper autofluorescence. So he examined this, these dots, and they found that these dots actually present initially in the acute stage of the disease. So here in the acute stage, all these lesions are representing the spots of the disease. And if you look carefully inside these spots, you will find a fine dots on these, in the center of these spots. So what does this represent? And this is during the intermediate phase. So angio-OCT showed that these spots actually an RPE, a debris of the photoreceptors on top of the RPE. So this is the two pictures in the left side are the in-fast angio-OCT at the level of the photoreceptor. You can see these spots represent the hyperreflective areas where the dots are the hyperreflective materials projecting inside the outer nuclear layer. And during the follow-up, you can see this the reflective areas become more ISO, and these dots start to disappear. So the adaptive optics, again, they tested these dots, and they call it the humble dots, because this is what we usually see during the examination when we see the foveal granularity that was described initially in patients with MEWDS. So in adaptive optics, they found these dots is like hyperreflective dots on the top of the RPE that is have a very characteristic appearance on the adaptive optics. You can see in the image C and D. So these dots usually hyperreflective, surrounded by hyperreflective halos, which represent the area of the RPE of the photoreceptor debris on top of this RPE. So before diagnosing any patients with MEWDS, we should exclude other masquerades that can present with MEWDS like picture. So this paper published this year by last year's study by David Serrar regarding the masquerades of the MEWDS, and he mentioned several cases that can present initially with MEWDS like picture. So the OCT will show this alternating hyperreflectivity and hyperautofluorescent lesions and autofluorescence. So this is a case of primary vitreoretinal lymphoma. And another patient with multifocal choroiditis, you can see the autofluorescence is very characteristic here. The lesion here looks like a MEWDS initially without retinal loss, but this, disease tends to be multifocal choroiditis. Retinal vasculitis, here is very obvious, the extensive vascular sheathing, but what was peculiar regarding this case is the presence of the photoreceptor loss and choriocapillaris flow void at the level of when they do OCT. A very interesting thing is the syphilis. So syphilis can present with MEWDS-like picture, as you can see here. And the most interesting thing is that a few reports in the literature they mentioned spontaneous resolution of acute syphilitic posterior placoid chorioretinitis, as we can see in this patient. So this patient present initially with what looks like a placoid lesion, but during the follow-up of the patient while awaiting the syphilis serology, these lesions start to disappear. So we know that nowadays we have a few cases of syphilis here in Riyadh, and we should keep this in our minds. When we have an outer retinal affection, we need to examine the retina carefully to make sure that there is not, no placoid lesion, yellow placoid lesion that we are not seeing, clearly. When we talk about MEWDS, as I said before, there is another, entity of MEWDS. It's called AIBSE or AIBSE, acute idiopathic blind spot enlargement, which is thought to be a part of the MEWDS. So in this disease, the lesions usually localize around the optic disc. So usually those patients present with shimmering of photopsias, enlargement of the blind spots, and usually they maintain a very good vision. So the problem with this disease, it can mimic actually optic neuropathy, but when you do the optic nerve function, it is usually normal. So the visual acuity, the color vision will be normal in those patients, and even they don't have an APD. But the OCT and autofluorescence is very characteristic. So you can see the outer retinal loss just around the optic disc, and the autofluorescence of the routine angiography will demonstrate the lesion is only localized around the optic nerve. And when you do the visual field test, you will see that the enlargement of the blind spot that improve with the time. So this is the autofluorescence in a patient with AIBSE, and you can see 6 weeks after the visual feature improvement in the enlargement of the blind spot, and the lesions in autofluorescence start to decrease. And this is the fluorescein angiography. As I said, you will see the lesion usually surrounding the optic nerve. Another disease that can affect the outer retina, which is a little bit challenging, is AZOOR, acute zonal occult outer retinopathy, which was described by Gaz in 1990s as to be one of the white spot syndrome. However, this disease, you will not see a white spot or yellow spots. So the fundus findings initially appear normal. However, at this stage, if you do electrodiagnostic, you will see a lot of changes despite the normal fundus appearance. So so these lesions usually tend to be connected to the optic nerve, and usually it affects a sector of the retina, and sometimes you will find a demarcation line. Unlike MEWDS, usually these lesions leave a lot of RPE mottling, as we can see in the picture to the right side, and tend to have a very aggressive behavior, unlikely MEWDS disease. The interesting thing about this patient is the autofluorescence, as a trizonal pattern has been described. So you can see in the right side, the zone 1 is the normal zone. And as I said before, those patients usually have foveal sparing. However, in the advanced disease, the fovea can be involved. And zone 2 is the zone in the middle between the atrophic zone and the normal zone. And usually these don't have a speckled hyper-autofluorescence. And the third zone, which is the atrophic zone superior to the disc, as we can see in the left eye and in the right eye as well. And if you do OCT at these lesions or at this atrophic area, you will find the outer retinal loss. Two entities have been described in the literature as a part of AZOOR, and all of them they labeled as AAOR. So the first one was acute annular occult retinopathy, and the second one is acute annular outer retinopathy. I think these terms make a lot of confusion to us, but simply it is like it's AZOOR, but you will find in those two diseases a line or demarcation line that separates the normal retina from the affected retina. And usually in acute annular occult retinopathy that was described by Gaz, this gray line usually disappears with time. And the other one is acute annular outer retinopathy, which was described also as a part of AZOOR spectrum. This disease usually presents with a rim of the retina that is affected around the optic disc in annual distribution. So you can see in this patient, there is a grayish or yellow lesion surrounding the optic disc that's causing hyper-autofluorescence in the autofluorescence and gives a MEWDS-like picture. So this disease for me is very similar to idiopathic, acute idiopathic blind spot enlargement, but the only difference here is that the demarcation line. So you can see a very nice circle surrounding the disc. They mentioned that the outcome of this disease is more severe than the AIBSE. I feel is the same because most of the published case reports regarding this disease, they report a variable outcome. So like this patient, he presented with a MEWDS-like picture, and the hyper-autofluorescence surrounding the disc have a very well demarcation between the normal and abnormal retina, but at the end, this patient improved. This is another patient with acute annular outer retinopathy, is also presented with a circle surrounding the optic disc. So the difference here is you can see this circle is very well demarcated. However, in a very few patients, this circle can extend beyond the arcades and give AZOOR-like picture. So because this disease is very rare, we don't know really the natural history, but we know that sometimes it can give RPE mottling and a lot of changes in the retina. This is after observation. You can see the blind spot becomes small, and the outer retina, the outer retinal photoreceptor layer is stored here. So we finished from the OCT findings that give you outer retinal loss, inner segment, outer segment loss. Now we will move to another spectrum of primary idiopathic, primary inflammatory choriocapillaropathies, which is multifocal choroiditis. And as I said, in our region, when we talk about multifocal choroiditis, we should exclude TB, sarcoid, syphilis, and other infectious entities before labeling this patient as idiopathic. And in the literature, the idiopathic multifocal choroiditis has been classified into four subcategories. The first one is idiopathic multifocal choroiditis, multifocal choroiditis with panuveitis. So those patients usually have a very mild vitritis or even anterior chamber cells. Diffuse subretinal fibrosis syndrome, and most of the previously published paper, they thought it is a part of multifocal choroiditis, but they end up with the fibrous bands under the retina connecting the old lesions. PIC, which is the most aggressive part of idiopathic multifocal choroiditis. So regarding the PIC, this disease is very interesting. We know that this disease is usually affecting the young myopic females, and it's a part of multifocal choroiditis. However, the lesions tend to be smaller, so the size is like 100 or 300 micro, and those lesions commonly affecting the posterior pole and rarely extending to the periphery. What is interesting about this disease is the OCT. So if you do OCT over the active PIC lesion, you will find this RPE elevation, as you can see here. So Spade and his colleague, he described this in several papers, and he feels that this lesion starts actually under the RPE, and with time, it ruptures or it penetrates through the RPE into the retina, and the Brox membrane is usually intact below these lesions. So thereafter, a lot of reports came to describing this active PIC lesions or multifocal choroiditis lesions as an RPE elevation with rupture of this material inside the retina. Increased choroidal thickness have been also described in the literature to be associated with multifocal choroiditis. However, I don't feel this very specific because any type of posterior uveitis can increase the choroidal thickness. So it's not very helpful in the diagnosis, but it can help you if you want to follow the patients after the treatment. So this is the patient after the treatment. You can see the choroidal thickness has decreased. Another entity that categorized under the primary inflammatory chorioretinopathy is acute macular neuroretinopathy, AMN. It's a very rare disease that was described in 1975. This disease is very interesting because most of the time you will not see these lesions on blue light autofluorescence, and sometimes not in the examination. But the OCT is very interesting. You will see this hyperreflective line affecting mainly the outer plexiform layer. And then this is, in hyperacute stage. After that, this hyperreflectivity will move down to affect the outer retinal layer. And clinically or in multicolor image, you will find this reddish brown lesions have a wedge shape pointed toward the fovea. So, so as I said, what is interesting regarding this disease that the autofluorescence, the blue light autofluorescence, the fluorescein angiography and ICG always or most of the time are normal. So you will not pick this disease with this this modality of imaging. So the best way to detect this lesion is the near infrared imaging or the infrared. So these images are you can delineate the affected area in the deep retinal layers that cause the patient's problem. So those patients usually are young patients. They tend to present with a normal vision most of the time, and they usually present with the scotoma that can improve and can improve with time, and some of patients can persist. So if we go back to the basics, if we have anything that affects the superficial part of the retina, it will cause you a cotton wall spot, which we can see it clearly in the OCT as a nerve as a nerve fiber layer infarction. And if we have a disease that affecting the intermediate the intermediate capillary plexus in the retina, it will give you a characteristic lesion called PAM, paracentral acute middle maculopathy, which was described in 2013 by David Sarraf. And you can see that this hyperreflective line in the inner nuclear layer. So PAM is not a diagnosis, but it's an OCT finding indicating the intermediate retinal capillary plexus ischemia that can be associated with cerebroretinal artery occlusion, as in this case, or ischemic CRVO, CREO, or anything that can affect this layer. The deep capillary layer in the retina, it usually gives the AMN, or acute macular neuroretinopathy, and you can see this hyperreflective line affecting the outer plexiform layer. With the arrival of NG-OCT, AMN was studied by many papers, and they could localize that the lesion affect the deep capillary plexus. As we can see here, in the top one is during the acute stage, and in the lower row here, you can see during the follow-up, we can see restoration of the vasculature at the deep capillary layer. We will move now to the Placoid Chorioretinopathies. So Placoid lesion, Placoid mean is a plate-like, so it's usually a flat lesions at the level of the RPE that is very obvious clinically. So this term is used to describe a group of the disease that can be idiopathic or infectious. In our region, before diagnosing any Placoid disease, we need to make sure that we are not dealing with a TB. This is very, very crucial. So for the idiopathic Placoid lesions, several subcategories have been described before. MB is one of the common things that we used to see, not here, maybe outside the kingdom. And there is a subtype of MB called acute retinal pigment epitheliopathy or Krill disease. I remember Pierre Skin, he liked to call this disease as mini MP. So it's very small lesion that have a very good prognosis and outcome. Serpiginous, usually these lesions are rare, bilateral, and I don't think that we have a lot of idiopathic serpiginous in Saudi Arabia. However, it's also rare in Western countries. Relentless Placoid Chorioretinopathies is an aggressive type of multifocal serpiginous or ambiguous lesions or persistent placoid maculopathy. So all these lesions share similar findings of multimodal imaging. However, for the last few years, there has been a lot of debate regarding the pathophysiology of these placoid lesions. Is it either RPE disease or a choriocapillaris disease? And actually, I did an extensive lecture review regarding the multimodal imaging in the placoid lesions, and I will show you now where the lesion usually starts from. So classically, for any placoid lesions during the active stage, as I said before, HDs has hyperacute, acute, subacute, chronic, and if the patient is partially treated or treated, also it gives, specific findings. But here I will talk about the active or during the acute stage of any placoid lesion. So usually in autofluorescence, you will see these lesions causes hyperautofluorescence. It means that the RPE is affected and it starts to suffer. That's causing the hyperautofluorescence. The OCT is very characteristic in those group of disease. So you will see the outer retinal hyperreflectivity. And the ADI OCT, it shows transient increase in thickness. And as I said before, the ADI will not help you to diagnose those diseases because it might not indicate, the activity. It might help to monitor the patient or to monitor your treatment if the ADI shows increase in the thickness at the primary diagnosis. FFA is classic in all this group of diseases. It's called early hypo and late staining. And ICG is usually show a persistent hypofluorescence. And the angio-OCT in all these diseases showed choriocapillaris flow void. So you can see in the right side, this is the case of MB, and you will see that in the right, in the B, it causes hyperfluorescence. It means those lesions are active. In the fluorescein angiography, usually it causes hypo and in the early and hyper in the late. But in the D picture, which is the angio, which is sorry, the ICG, you will see those regions give you a geographic distribution in MB regions, and it can detect more lesions than what we could see clinically or in the autofluorescence. In the G picture, you will see that this is the angio-OCT at the level of choriocapillaris. It shows clearly the blood flow void at these lesions, which indicate that this is really a choriocapillaris ischemia. So if we have any placoid lesion, and if we do OCT over this placoid lesion, so either ampy or serpiginous or the other entities, so it causes outer retinal hyperreflectivity, as you can see here. And sometimes you will see that the area underneath the RPE showing hyperreflectivity, indicating ischemia. However, you cannot see this in all patients. This is a classic case actually. So regarding AMBI, I will just touch a few things. Before diagnosing AMBI in our region, we should exclude TB. This is a very important thing. And those patients, if it's pure AMBI, those patients can carry a serious disease because it can be associated with neurological manifestations such as meningitis, cerebral vasculitis, and rarely stroke. So let us take a look to this multimodal imaging in a classic case of AMBI. So in A and B, in the top, you will see this is a fluorescein angiography. It shows classically early hypo and late staining of the lesion. And C and D represent the ICGA. You can see persistent geographic distribution of hypofluorescent lesion. And you can see in E1 and F1, this is the angio-OCT at the level of the outer retina and choriocapillaris. It shows the choriocapillaris blood flow void, indicating ischemia, and the OCT showing outer retinal hyperreflectivity. What is interesting in this case, if you look to the I1 picture, the one on the right side, the autofluorescence, it causes autofluorescence initially. So this is actually in the hyperacute stage. It initially gives you a hypoautofluorescence, and with time, it gives you a hyperautofluorescence, as you can see below in I2. This indicates that the autofluorescence lag behind the changes in angio-OCT, OCT, FFA, and ICG. And this is why we should not use an autofluorescence to detect the disease activity. However, we can use to monitor the patient progression over time. This is another case of placoid lesion. This is a case of serpiginous choroiditis. This is one of my patients that I've seen during my fellowship. So you can see initially these lesions are white, yellow, creamy, deep subretinal lesions, and the autofluorescence in B, it causes hyperautofluorescence. And if you do OCT over these lesions, it gives you, outer retinal layer hyperreflectivity. And during inactive stage in D and E, you can see clearly the area of atrophy of the previously active disease that causes hypoautofluorescence in the picture E, and OCT over these lesions showing outer retinal atrophy with reverse shadowing. This is another case of serpiginous-like choroiditis. It's a case of TB, and you can see during the active stage A and B, yellow subretinal lesions with some RPE changes. And in C, this is the autofluorescence. It shows the hyperautofluorescence of these active lesions. And if you do angio-OCT over, at the level of the choriocapillaris, you will see clearly the choriocapillaris blood flow void. And in E and F, this is the fluorescein angiography characteristic, early hypo and late staining. And G and H, this is the ICG. It shows persistent hypofluorescence during the all frames. This is another patient. You can see in the picture A and B. This is old lesion, old placoid lesions that start to reactivate at the edge of the disease. And if you do OCT at the edge of this disease, an area of hyperautofluorescence, it gives you outer retinal hyperreflectivity. And you can see in C and D, this after treatment, this hyperautofluorescence resolved. It means that disease is inactive. So because we do have a lot of serpiginous like choroiditis, I did this table even also during my fellowship to summarize what are the differences between these two things, between the idiopathic serpiginous choroiditis and TB-related serpiginous choroiditis. So first of all, if we usually see a serpiginous choroiditis in area endemic with TB, like in our region, and not necessarily those lesions start peripapillary as we do see in idiopathic. And those lesions tends to extend beyond the arcade to the periphery, and used also those patients usually have a significant amount of vitritis, not like what we do see in idiopathic one. The autofluorescence is very interesting to compare these two entities, because in idiopathic one you will show, during the inactive stage, the idiopathic serpiginous choroiditis shows a homogeneous hypoautofluorescence. However, in TB serpiginous like choroiditis, it shows a stippled hypoautofluorescence. Still, we don't know why. The difference between these two diseases. FFA and ICG usually there will be no difference. The OCT is very characteristic in serpiginous like, the one associated with TB. It shows the disruption and increase of outer retinal reflectivity, and you will see also some increase in the choroidal reflectivity, choroidal infiltration. Sometimes you will see RPE elevation, drosinoid-like deposit under the retina or under the RPE, vitreal hyperreflective spots, and choroidal granulomas. So as I mentioned, after the arrival of angio-OCT, we could see a lot of things that we cannot see before when we use the FFA, the conventional multimodal imaging, including FFA and ICG. However, don't forget that image artifacts are common when we use angio-OCT. So still, we don't know how accurate the angio-OCT to be used to diagnose and to follow those patients with primary inflammatory choriocapillaropathies. And we know that also from the those diseases are rare. So to comment or to use the angio-OCT on these patients and to put our theories, we need to test these machines first, and in a large and to select a large volume of patients with the same disease, and to test our to check if we can have the same or different results. So in summary, for any primary inflammatory choriocapillaropathy, we should first exclude any infectious cause or other neoplastic or systemic vasculitis. And then we try to put the case in one of the well-defined categories. As I said, is it an outer retinal problem? Is it multifocal choroiditis? Or is it a placoid lesion? So we should know from the first which layer of the retina is affected. And if we don't know, or if the case is intermediary, is not classifiable, so we need to observe the lesions closely and to repeat the multimodal imaging if possible. If you see the lesions are persist or getting bigger, so you can introduce corticosteroids and other immunosuppressant lesions, but make sure that you are not dealing with the TB. So just I hope that I did not confuse you. I just want to put some of the OCTs. If you have any active yellow-white dot in your clinic, and you have only access to the OCT, do the OCT over the lesion, and if it shows outer retinal hyperreflectivity, think about the placoid things like serpiginous-like AMBI. If you have this RPE elevation or subretinal deposit, under the RPE, think about PIC or multifocal choroiditis. And if you have a yellow lesion, that OCT shows outer retina is affected mainly, I mean, the photoreceptors affected mainly think about MEWDS, AZOOR spectrum, or masquerades such as syphilis. So by this, I will conclude my talk, and thank you very much to you all.
Thank you, Dr. Abdulrahman, for this very nice and well done explanation of this usually confusing and difficult topic. I remember in residency, this topic really gives people a lot of confusion, and nobody really has a nice explanation to it. And I think in this era of multimodal imaging, it really makes things at least less or easily classifiable. I'll open the floor for anybody who has any questions or comments. Any questions from the audience?
الو السلام عليكم دكتور
وعليكم
عبد الله،
السلام.
كيف حالك؟
هلا
معك
دكتورة،
فدوى
كيف
العادل.
الحال؟ الله يحييك.
الله
يا هلا والله،
يحفظك.
حياك الله.
عبد الرحمن, you were amazing. MashaAllah, a great talk. You covered it beautifully. All the updates or controversies in regards to etiologies. Allah يعطيك العافية. I had one comment in regards to mute. ما أدري يسمعني دكتور عبد الرحمن ولا؟
Yeah.
Yes, it's very clear.
اي so لاني قطع الصوت وما سمعت كويس. So يعني David Saraf believes that it is a primary viral photoreceptoritis, as he calls it. And then you mentioned something about the RPE. I would like you just to elaborate on it again, please, if you don't mind.
Yeah. So as I mentioned that David Saraf I mean, he's thinking it's more of photoreceptoritis rather than a choriocapillaris or RPE. But the paper that was published last year by Giovanni Stawingi, he clearly demonstrated that in the acute stage, the RPE can be affected. And the point that he mentioned in his paper that the shadowing that you can see through the RPE cannot be explained by the photoreceptor damage only. So it should be an RPE swelling and the melanosomes inside the RPE start to spread around. So the light will pass it through this RPE and causing shadowing. The other point is the using of adaptive optics showed that the outer photoreceptor is affecting more than the inner segment of the photoreceptors, which indicates that most likely it happens due to the RPE rather than a photoreceptor. So still, to be honest, we don't know exactly where the lesion, where the disease starts, at which level. So it could be a choriocapillaris. Still, we don't know. As I said, the paper that was published by the Karl Harbert, he was argued the accuracy of using NG-OCT to test the choriocapillaris. But it seems from what we can see from the clinical or from natural history of the MEWDS with spontaneous resolution, it seems more of the outer retina, either RP or photoreceptor.
Wonderful. Thank you again for this wonderful talk.
You're most welcome. Thank you.
Any other comments or questions? I think, mashallah, Abdulrahman, I explained everything in a very nice fashion. I will conclude this session, and I thank you, Dr. Abdulrahman, again for his time and effort and really making the talk nice and very great in drawings and illustrations and classification. Thank you, Abdulrahman, and it's a pleasure to have you.
Thank you. Thank you so much.